So, good afternoon, everybody, and welcome. Today's conversation focuses on one of the most consequential efforts in American healthcare, the current transformation of rural health. The Health Transformation Program, it represents a major national commitment, but its success is not going to be determined by funding and policy alone. The real test will be what happens in rural hospitals, in clinics, in communities, in homes, and whether this opportunity can be translated into practical, sustainable models of care. And that's the purpose of today's discussion. So we'll begin with a federal perspective on the program's design, implementation, measures of success, and opportunities for engagement now and in future years. We'll then move to the state level, specifically Alaska, to explore how states can move from application to execution, to balance immediate rural needs with longer-term transformation, and identify external partners that can add real value. Then we'll shift to how health systems, connectivity, technology, remote care, AI can support sustainable rural healthcare models. And then finally, we'll discuss what effective implementation requires: lower burden partnerships, workforce training, quality systems, lasting local capacity. At HEI Partners, we've been lucky to support each part of this RHT program ecosystem. And our goal today is simply to enable sharing of what works, what doesn't work, and what we are collectively learning. And ultimately, we have the same goal. How do we enable high quality healthcare to rural and underserved community, the homes where most of us at HEI Partners were actually fortunate enough to grow up? So this hour, it's not going to answer every question, but it can clarify the work ahead, identify what matters most, and move the conversation from ambition to implementation. So thank you, everybody, for joining us. So to begin, I'm very pleased to welcome Emily Chen from the Centers for Medicaid and Medicare and Medicaid Services. Emily led the team which designed and authored the RHT program. She'll help us understand how the program was structured, where implementation stands today, and what success could look like in the years ahead. Emily, thank you for being here.
Hey Ken, thank you so much for having me here today. Just
You,
confirming you can hear me well.
yes, perfect. And before we get into a bunch of questions, can you share just a little bit about your background and your role in developing the program?
Yeah, sure. My title here at CMS, or the Centers for Medicare and Medicaid Services, is I'm a senior advisor to the CMS administrator, Dr. Oz. So, as part of that role, I work on a number of different topics in my portfolio, including what took most of my time last year is writing the Notice of Funding Opportunity, or NOFO, for CMS's Rural Health Transformation Program. And the NOFO is essentially the program structure and design and explanation of how to apply for funding from the state perspective.
Well, thank you for we've known each other for a while, and it's definitely been an incredibly intense and in-depth and granular effort. And again, from the stories that I've shared where I've grown up, it's an amazing opportunity. So with that, can you describe how the program's designed?
Yes. Yes, I'm happy to. I'm going to start with a relatively macro level perspective to ground folks who may not be as familiar with the program. So, the Rural Health Transformation Program, or affectionately dubbed RHTP, was written into law by Congress in July 2025. Just to take a little bit of a step back, where we stand today, a year ago, the program was not even written into law. The program didn't exist.
Hmm.
So, what it is it's $50 billion that CMS awards to the 50 states, with 10 billion distributed each year for 5 years. And fundamentally, the program is designed to tackle the deep-seated and systemic challenges that have created disparities in health outcomes for the over 60 million Americans who live in rural areas. It's truly a historic, once in a generation investment to empower states to really transform their rural health systems. So by law, Half of the funding, or 25 billion, is distributed equally amongst all states with an approved application for the program. And as a spoiler alert, all 50 states applied and received funding. So what this means is that each state will be awarded at least 100 million each year for each of the 5 years of the program. And then the other half is distributed based on a formula that takes into account things like the state's rurality, policy actions, and the quality of a state's proposal and follow through. Um, so specifically for rural communities, this isn't about perpetuating the status quo. It's about providing the resources for truly transformative and sustainable change. And with that, there's three areas of the program in particular that I want to highlight. The first is this concept around transformation. The second is around sustainability. And the third is about what it means to be a federal and state partnership. So first on transformation, this word was used pretty intentionally in the naming of the program. The program funding is not meant to replace existing reimbursement pathways. It's meant to provide funding for, again, transformative initiatives. The types of funding that can be used for this program may be things that people don't normally associate with CMS. So, for example, investing in tech and hard infrastructure, building out a stable and local healthcare workforce, or paying for startup costs to design and launch new programs, processes, and care models. This second thing I wanted to highlight is sustainability. So Congress designed this as a 5-year program, and CMS is responsible for being a good steward of the funding. So we've placed a pretty big emphasis on sustainability of the initiatives that states are going to execute, where we've steered states away from funding perpetual expenses that may hit a funding cliff at the end of 5 years. And then finally, the last flag is around state-federal partnership, which I'm sure we'll touch on later as well. But what this means is that from the CMS side, we launched a program office with about 25 full-time employees here at CMS who provide technical assistance and learning resources to the states. And we also act as a convener to help share best practices and ideas and provide strong program oversight. And ultimately, however, this program is state-led. We didn't think it was appropriate for us to sit in DC and dictate what makes sense for rural communities across the United States. And so truly, we empowered states to be able to design programs and initiatives that work best for the unique needs of their rural communities. And so states are leading the crafting of their initiatives, what their strategic goals are, and how they decide on subawarding and actually executing the follow through on their projects and activities.
And as a status update, where are we in the program's implementation process?
Yeah, for sure. So, high level timeline, this program was written into law last July 2025. And then CMS designed the program structure and instructions on how to apply over the summer and the fall of 2025. And then states applied and were ultimately awarded funding by December 2025. So for this first year of the program, I mentioned that there's 5 years, and even though there's one application, there's an award that's made each of the 5 years. So for the first year, dollars have been released from CMS to all 50 states, so that the states can get to work towards achieving and standing up the many initiatives that they wrote about in their applications that I'm sure many of you have read about. Um, the states, from CMS's perspective, have project officers who have been allocated to them by CMS to support in their implementation. The project officers meet with the states multiple times a month to convene on project milestones and the progresses, talking about challenges and successes. And we really hope that CMS is a collaborative partner for states in helping them successfully bring their visions to light. CMS also hosts monthly webinars for states on various topics to help them along the way. So, for example, we held webinars on procurement, And we're regularly updating the cms.gov website on RHTP with additional resources such as updated FAQ documents. And then from the state perspective, which I'm sure Emily Ricci can talk a lot more about in depth, at least from Alaska's perspective, is that the states are making key hires as they're building out the state level RHTP teams. They're regularly updating their websites with details on their initiatives, and they're continuing to engage with prospective participants that are necessary to execute their projects within their states. So those on the ground executors like providers and other community members. So as a reminder, states are required to obligate their first year awards by the end of October 2026. And what this means is that they have to have signed contracts for where the money that were awarded in their first year is going by this time. So that means that right now states are really, really focused on posting funding opportunities on their own state websites and reviewing and scoring applications for these opportunities and ultimately making awards. And so where CMS is expecting a lot of solicitations, reviews, and awards to be made over this summer period into the early fall, and we'd expect to see initiatives really taking shape towards the fall and winter periods of this year. And just again, another reflection of how mind-boggling it's been that, again, less than a year ago, um, this program was actually written into law.
It's amazing. And then, to keep on time, because we do have a packed agenda today, when we talk to the different stakeholders, whether they be hospitals, companies, CHWs, individuals in the community, oftentimes we get the question, is it too late for me to apply? What's your thought to that?
No. The short answer is no. It's not too late to apply. So a couple of thoughts about that. Again, would reiterate that it's a 5-year program. So while there's only one application, there are 5 award periods where the state is awarded, chunks of funding. And who the state partners with in future years may not be identical to who they were awarding for their first years. There may be shifts based on early signals on performance or how states are staging out actual execution of their initiatives. So I think for funding that's being awarded in future periods, states are already really actively thinking about how do they engage the key stakeholders that would participate in state procurement processes and get them ready for those future years of funding. So that's the first thing. And even with the first year of funding, it may not be too late to participate even in that. So depending on the procurement strategy of the states, states may be awarding to one entity that ultimately may need to again subaward in order to execute that initiative. So there's a lot of ways to be involved. It's a once in a generation opportunity, and we really hope that you'll support us in making these visions a reality.
Well, thank you for joining us. I know it was a very short, brief, intense session, but looking forward to talking further. And I can't think of a better transition. Kate, the mic is yours, and we'll switch over to the state level.
Thank you so much, Ken. So for people who do not know me, my name is Kate Merton. I'm part of Health Equity Innovation Partners, and it is really my pleasure to introduce Emily Ricci, who is the Deputy Commissioner and State Medicaid Director at the Alaska Health Department. Emily, thank you so much for dialing in today and giving us some of your time. It would be great to first hear what your role is in Alaska, and then I have a couple of questions I would love to ask you.
Absolutely. Good morning or afternoon, everyone, depending on where you're at. So in my role, I act as a deputy commissioner within the State of Alaska Department of Health and as the Medicaid director. And so I oversee the different divisions and sections that make up Alaska's Medicaid program. And I also oversee the Office of Health Savings, which was intended to focus on some of innovations within our Medicaid program. And when the Rural Health Transformation Program came into being, that office is now leading the Rural Health Transformation Program in Alaska.
Thank you so much for clarifying. We're really pleased to have you because we're going from the story of Emily at the federal level, and we'd really love to hear more. That as a state, and you are on tight timelines because you went from application and now you're moving into execution. It would be really nice to hear like the reality of what has it been like designing something for a state such as Alaska, where you have to build something that can fit the rural needs on the ground, while at the same time having a sort of structure and rigor that you can be checking on the outcomes and what you're seeing. So how has that process been and how's it going?
Oh, I'm sure just like Emily Chen, it has been a whirlwind for probably the past 12 months. And not even quite 12 months. I love that you pointed out that it hasn't even been a year since the law took effect, and we have come through so much. So it's, I think like every other state, it's been very challenging in a lot of ways and very exciting. In Alaska, we have a really diverse population. I've had an opportunity to travel over the last few weeks to different areas in our state, and it just reminded me of how diverse the needs are, even within a state like Alaska, across different rural populations and rural communities. And so when we think about how to best use these funds, we started with reaching out to Alaskans and to community partners and to say, this is an opportunity that's here. What do you think? What are your needs? Because we know as a state, we had a very short time period to respond to the NOFO. I know Emily had a very short time period to write the NOFO as well, right? But for something, when you are trying to craft a 5-year, very large investment for a state like Alaska, it's not something that we can do in isolation, right? Sitting inside state bureaucracy. We have a lot of talent in here, but we are going to miss things and community needs, which is one of the reasons why if we want this funding to be durable, if we want it to be sustainable, then we have to be responsive to what the different needs and communities in Alaska want and need and view as transformative for them. Our job is to kind of help push from that system perspective to make sure the system is efficient and transformative, but it has to start at the community need. And so that's really where we started when we tried to both design our application and then think about an approach to awarding funding.
Thanks for that. I know yesterday when we had a chance to catch up, we were talking about the very real tension that exists between how do you leverage funds for people who have very real needs right now on the ground in rural environments, and they're thinking, well, why can't this funding be used for X, Y, and Z, where I've already told you this is what I need, versus RHTP, which Emily described is really meant to be a transformation program. So there's a real balance that you're in the middle of trying to make sure you're dealing with the community, you're giving them what they need, but also making sure there is transformation going on and delivering care in a new way. How is that going?
It's challenging, and I don't think we're unique in that as a state. I hear this when I talk to other people that are working on this program in other states. We have a number of rural healthcare providers that have needs that are not fully met right now by the current system and by the reimbursement structure or by the nature of the services that they're trying to provide in a very rural, challenging area. And when they hear that there is funding available to help them be successful and be sustainable, immediately their mind goes to, which is natural if I were in their position, this is my need. I need a new X, Y, or Z. I need to build this. I need something. And that reflects the realities of where they are today. But what we're being asked to do with the Rural Health Transformation Fund is to think about what we want to look like tomorrow and in the future that is sustainable, that addresses the challenges that they have today in a long-term way. And frequently that is a different approach than just addressing the very real needs that they have today. And so that mindset, when we're asking entities that are on the rocks, right, that feel like their ability to survive is challenged by the environment that they're in, we're also asking them to think differently and to think about different ways that they can move forward. And that's really hard, right? Change is hard in general. Change when you're under duress is difficult. And so we've had a lot of really challenging conversations with organizations about what the funds can be used for. And there's a point where we're seeing in our state where people are really starting to shift from this is what I want it to be to this is what it is and how can I best leverage it and what are the opportunities that I didn't think about before. But it takes time, and time is something we don't necessarily have in this first year of the program. So there's that natural tension too.
Yeah, it's a very compressed timeline in the first year. There's a theme that I think we want to draw through the whole of this session, which is how to be a good partner. And I can only imagine the number of phone calls that you have got from potential partners and vendors and everyone wanting to tell you the greatest new thing. And I think it would really be great to hear sort of the reality from you of what makes a good partner. How should people be approaching the state and the health systems that you are working with if they truly want to be a partner and not just sell them something?
That is a great question. I always say Alaskans tend to be a suspicious lot, and for good reason. We've had a number of different great ideas where we've invested a lot of funds, whether that's state funds or federal funds in the past, and they haven't materialized into anything sustainable or durable. And sometimes there's adverse impacts to those projects that we didn't anticipate. And so people are very thoughtful about any sort of change to their system, again, because they feel a level of vulnerability, I think, in isolation. And so I think coming in as a good partner, if there are people that you know within the state, if there are entities that operate within the state, I would start by learning and listening and trying to understand what those challenges are, and then think about how you could work to address those challenges. But I have seen over and over again entities coming in with a great idea that may in fact be a great idea, but if they don't have that connection, if they don't build that trust, Alaskans will not be open to that. And I don't know that I don't know that that is unique compared to other states. I don't think it is. We see it even with state government. If the state comes in with a great idea and tries to push something, even if that idea would be beneficial, that's not always well received. And so it's a little bit of this push and pull relationship between really trying to listen and understand and then share opportunities to help address the challenges that you've heard.
So listening and building trust and really addressing their needs. Thank you so much for giving really clear and succinct answers in this whirlwind. Very much appreciate your time, Emily. And at this time, I think we were hoping to transition over to a conversation with our health systems. Jeff, do we have Dr. Dave and Becky available?
We're waiting for Dr. Dave.
Okay, in which case I know we are pressed on time. So perhaps, Ken, did you want to move forward and have the conversation with David?
Sure, of course.
We'll check in.
Yes. So, one of the threads that we'll talk about it later today is how health systems can turn rural strategy into really practical operating models. And the thing is that these models cannot scale or endure, more importantly, without the right foundation, connectivity, data, technology, all working together. And so to explore this, I'm very pleased to welcome Dr. David Rue, Global CMO of Microsoft. And we'll talk about broadband and technology and AI and making sense of all this. So, David, thanks for joining us.
That's my pleasure. Thanks for having me.
So let's get right into it. Let's talk first about digital infrastructure. So, affordable broadband, it's a major barrier in a lot of rural communities. And so, how should states build the connectivity, the data, the security, and if you can mention that really amazing partnership that you guys have been leading?
Yeah, so I'll start with something that people are real fascinated with, which is AI. And when you think of AI, you're blown away by all the amazing things it can do. But AI is highly dependent on data. And the data is not only used for developing it, but also making sure that it's applied appropriately on the data sets. And then when you think about the data, the data needs to be secure, it needs to be made interoperable, but it also needs to be made accessible, which then gets us down to the whole inner ground of the infrastructure, which is around connectivity, internet, broadband. And if we were to kind of take in aggregate rural communities, individuals living in rural communities, about anywhere between one out of every four or one out of every three persons does not even have access to high speed internet. So this is actually an issue around trying to address the haves and the have-nots, even within rural communities. And what we want to do is we want to make sure that everyone has equal access to the types of services that we're offering, which is going to start with making sure that they have a capability to be able to then tap into things that in the past may have been difficult, if not impossible. About a decade ago, Microsoft and a variety of partners began an initiative called the Airband Initiative, which was designed around trying to figure out ways that we can expand access through public-private partnerships and novel technologies to high-speed internet. But now we actually have an ability to enhance that capability with what we call LEO, or low Earth orbit satellite, and combining that with the digital infrastructure, the cloud, the cyber protections. We now have an ability to be able to do this at scale and across large communities. And so we're really excited about the opportunity to be able to combine LEO with the ability to provide the digital infrastructure, which will then give organizations the ability to make sure that every person can take advantage of the RHTP.
So once that fundamental infrastructure is in place, it opens up the world to so many different things, right? Diagnostics and RPM and telehealth, et cetera. Can you give us some more color and granularity about those types of stories?
Yeah, so one of the things we definitely recognize is that digital technologies can do a lot of things to solve some immediate problems. But if we were to kind of take a step back and just think about like what is the biggest problem that we're faced with in rural communities, it's the model of how healthcare is delivered. Individuals have to see a person, traditionally a physician, in a clinic or in a hospital. And it's just really up to the individual to find their way to that clinic and or hospital and then get an appropriate diagnosis, care plan, and then ultimately continue to see that clinician. Now, what we've recognized is that in a clinical visit, there's three components that happen all the time. There's a diagnosis component, there's a management component, and then there's a treatment component. So the diagnostics, well, originally it was felt that you had to come into the clinic or the hospital to get those diagnostics, whether it's the X-ray, even like vital signs. We now have an ability to push that out into rural communities, into people's homes. And so using the AI, the newer sensors and technologies, we can actually disintermediate that piece. We know that the management piece can be disintermediated and brought into people's communities and homes with telehealth, remote patient monitoring, and a variety of other areas. And we're now also starting to see potential where we might be able to take advantage of robotics and tele types of technologies, and even expanding the capabilities of individuals that have not traditionally been part of this overall process. I'm talking about pharmacists, nurses, allowing them to practice at the top of their license and beyond, using AI and protocols and telehealth to support. We've now got an ability to be able to then think about a new model of care in which we can leverage technologies to be able to deliver more care to more people. And that's what's exciting now about this, because it's not just about one solution, but it's really about taking it in aggregate and finding ways that we can address these bigger problems.
So we've sort of touched on the basic infrastructure, then we've talked about what I would consider to be a variety of inputs. And we'll circle back to this other question if we have time. But one of the things that's really key to this is yes, it's a 5-year bolus, and it's funding to try different things, but it's all about sustainability, right? Can you remember that conversation you and I? That was
Yeah.
fascinating,
Yeah.
fascinating.
Well, let's just start with the big issue that we're faced with. This program, while amazing for the next 5 years, is not going to be, unfortunately, around for the next 5 years after that, and the next 5 years after that. So during this time, we actually have to figure out a way to find a new model of care, validate that it actually is leading to not only higher quality of care for more individuals, but at a lower cost, and then find a mechanism where individual stakeholders would be willing to pay for it. And really, those stakeholders that are already paying for healthcare today, demonstrating that this will actually be done in a way that is a lower cost, more efficient way to do it. So how can we do that? I'll just give you one example because this is actually something that we're exploring with several states. One area is if we could take a look at AI to be able to apply it across a broad population and identify individuals that are very high risk for bad outcomes. We know that 5% of the individuals are responsible for 50% of the total cost. If we can find those before they actually have that catastrophic heart attack, stroke, blindness, things that we know really send them down not only the quality of life trajectory of like finding a worse quality of life, but also increase the cost dramatically. If we can find them, we might be able to change their trajectory and also the cost trajectory. So how do you do that? You go into the communities, you apply these, and there's a really extraordinary technology where we can apply this on a retinal exam. So with a retinal exam, you can find things such as diabetic retinopathy, cardiovascular disease, hypertensive retinopathy, four leading causes of blindness. So we're starting to do that. But what we've learned is that finding the disease is only the first of three steps. Because if you don't have enough resources to be able to manage these individuals, you're just going to create a big queue and people will never get seen. So we've now recognized that the second phase is actually applying AI to risk stratify individuals, get the highest risk individuals to care, but then manage the medium to low risk stable patients digitally, virtually, and with expanded resources. That's the second component. And if it was there that we would stop, it'd be fantastic. But ultimately, it doesn't matter if people don't change their lifestyle. So like the diabetes is still out of control, but you've got the identification, you've got the appointment. You have to find a way to make sure that they understand and are willing to change that lifestyle. So now we've come to realize that patient engagement, education, addressing social determinants is really a critical component. So it's really all three of those, but making it personalized for each individual and risk stratifying it so that we can identify the impact that it has on the highest cost individuals. That's what has to be done. That's the transformation that we're trying to do. And that's what AI and technologies can help us enable.
Well, I appreciate you joining us and sharing those thoughts. I know that everybody in the audience is likely just whetted their appetite to learn more. But as a plug for David, the guy's around. Look online at his LinkedIn. He speaks about this in so many different ways, and just like all the people on our panels today, incredibly knowledgeable, and most importantly, they all care, which is really, really, really important. So thank you, David, and I'll hand the mic over to Kate.
Thank you so much, Ken, and thank you, David, as always, really, really enlightening. So it's now my pleasure to move on to the health system part of the conversation. We're really lucky today to be joined by two of the leading health systems in the US who we know have already received some of the RHTP funding. First of all, we have Dr. Gaurav Dev, or G, who is a professor of medicine at UNC. He is also the director of UNC's Center for Thriving Communities and the Abacus Evaluation. And we also have Becky Buchan, who is the Senior Vice President of Innovation and Transformation at OSF, which is a health system in Central Illinois. Thank you both for making the time today. And we're looking forward to having a conversation kind of leading on from what David said, is like you can have the greatest technology in the world and get patients lined up, but you are the guys on the front line actually having to work out how that gets done. So first of all, G, if you wouldn't mind sort of briefly describing where UNC is as one of the roots hubs for North Carolina, that would be great. And then I have some questions about connecting with the community for you.
Yeah, absolutely. So, good morning or good afternoon, wherever everybody is. I am I'm one of the small aspects of the larger initiative that the UNC Health and its anchoring partners, Granville and Vance Public Health Departments and Piedmont Health Services within North Carolina are leading as part of Region 4 hub. I am leading community needs assessment and the initial hub action planning, and then we would be transitioning into phase 2 after these first 3 months, and moving into sort of more of a robust, comprehensive, learning collaborative, more or less, I would say, very intensive community engagement and informing the activities and the priorities that we have identified and the solutions that we plan to implement. So we are at the very starting phase of this work. We just got our contract from NCDHHS, and so in the next few weeks, we will be rolling and rocking. Yes.
Okay. So given that, thank you for describing the role that you have at UNC. I know a lot of your career has been focused on how to actually deliver care in rural environments and really connect with the community before you think about sort of deploying something for them. So from a partnership and maybe the technologies that people are looking to implement, what should health systems be looking at before they start designing care, let alone deploying the care? What are some of those key things that you have top of mind that you're going to be doing in North Carolina?
Yeah, so that's a great question. So one of the biggest mistakes that health systems typically make is to assume that because they have data, they understand the community. Data is important, data are essential, but they don't tell the full story. So before we design any solutions, we have to make sure that the health systems understand sort of the lived experiences, the assets and priorities within the rural communities, and the strengths that the people bring to the table that they hope to serve, the health systems hope to serve at the end of the day. There are three things that I'll quickly mention. First of all, I think Emily mentioned this previously. You know, rural communities are incredibly diverse. In my state, North Carolina, there isn't one single rural North Carolina. We're made up of 100 counties. Our Region 4 includes 14 counties. These counties differ in their demographics, economics, cultures, available resources, historical relationships with their healthcare institutions. So a solution that might work well in one county may definitely not be appropriate just a few counties away. I mean, I'll give you a good example. There are a couple of counties in our region that don't have a hospital, whereas you have these 3 or 4 urban counties with large hospital systems, whether it's UNC Health, Wake Health, Duke, or ECU. So there's this whole aspect of diversity that we have to take into consideration and make sure that not one county is overshadowing the other counties. So that's the first point. Second, meaningful community engagement has to happen at the beginning, not after the decisions are made. Community members, local organizations, public health agencies, faith
Mhm.
leaders, schools,
Mhm.
patients, they all need to be partners in defining the problems and prioritizing the needs before we can identify and implement the solutions. Ultimately, those communities are the ones that are going to help shape the work. The solutions will be relevant and more trusted and has the capacity to be more sustainable if we make sure that the communities engage. And then the last point that I want to make is the point of the rural transformation, in my opinion, is not simply about increasing access to healthcare services. There's a whole host of things, especially social determinants of health. And I think David mentioned this, which is, there are many sectors, transportation, housing, broadband access, education, food security, workforce development, and workforce availability is super important when it comes to designing and implementing solutions. So that coordination needs to happen from the get-go. At the end of the day, I'll mention this. Communities should not be the subject of transformation. They should be the architects for the transformation. So I'll stop there.
Mhm.
That is a wonderful way to put it. And I saw Becky nodding during that, and I know she truly understands some of the aspects you were talking about because OSF. Becky, do you want to describe sort of the variety of institutions that come under the OSF umbrella? And then I have questions for you around data and analytics.
Yeah, so we support our ministry. We're a Catholic healthcare organization. We really support a large footprint of for Illinois, largely focused on rural. We have 17 hospitals, again, to your point, varying from critical access to kind of community-based to, your quaternary care kind of hub destination center. And so all things in between that. And I don't know, Kate, if you want me to talk then also a little bit about kind of what we've done over the course of time to kind of build some of that transformation.
Yeah, what I was interested in, because like G makes a really good point that you shouldn't be doing anything to the community unless you have asked them first. And I think
Yes.
the unique things about OSF is that you have spent a lot of time in the transformation innovation space actually developing how do you do that, so that as you've now got into the stage now of thinking about how you're going to be involved in RHTP, you can use that data and analytics, check it is working with the community, and then also use it to be sort of checking that the outcomes that you're seeing are actually hitting all the goals and the targets that Emily was talking about. So I'd love to hear some of those steps.
Yes, so we developed based on kind of a vision for innovation, really recognizing, to transform healthcare, we needed to introduce innovation. And so about 10 years ago, really started to think about what that looked like. One of our focuses really was around the transformation of rural healthcare specifically. And even before, so we did, quite a bit of research actually around what it would take from kind of that social drivers perspective, understanding our communities, going out and meeting, but also then collecting some of that data, even before there were systems to collect the social drivers, really understanding what those things were, what the needs were, connecting with our communities, whether it's our community-based organizations, whether it's our community colleges, again, really understanding what that is. And then working with the communities actually to do some of the testing and get them excited about, knowing that we have to transform healthcare, but doing that with them collectively. And so we've done a lot of work over the course of time, certainly being able to test, but also deploy. We're really fortunate to have our on-call digital health. So it's our digital health arm that has deployed our community health workers, other digital solutions. But again, kind of I would say anchoring back to the data, if you will, is really important, bringing in not just what's going on from an EHR perspective or when they are in our care, but also bringing in the social drivers, connecting to our community health workers to bring that data in to better know those things that we need to be solving for, and then bringing that out and connecting with our communities in a different way. So I've established a lot of programs from that point, thinking about, again, kind of some of the personalized or precision outreach that we can do based on condition, based on need, but then also really driving some of that kind of guided care navigation, depending on what their needs are from a local perspective. And then finally, kind of the across the continuum, being sure to connect them back from a chronic disease perspective and management of that.
Yeah, so you highlighted, like, G, that understanding the social determinants of health as well as the clinical aspects that are going on has been incredibly important as you help the patients navigate through. I wanted to go back to the question I initially asked Emily Ritchie, which is around how can you be a good partner? Because I can fully understand that you both, in the positions that you're having everyone and their mother like call you and say, hey, I've got this great new solution. And it's almost like, hey, we haven't even come up quite with the plan yet, let alone do I want to know if I want to work with you. So from a health system perspective, and start with G first, what do you think really makes a good partner with a health system who has been provided funding from RHTP but has got a big body of work ahead of them?
Yeah, in my opinion, the most effective partners are the ones that listen, first and foremost. Second, whatever that they're proposing has a good fit between their solution and the local context, and that they can only find out by listening first. The third is that there has to be more or less support for implementation. And what I mean by that is, especially in the rural healthcare systems, there is, all kinds of barriers. There's workforce shortages. They don't want to add another thing and then have to deal with that when they already are dealing with many things on their plate unto itself. So a partner that comes to the table needs to understand the context or the contextual issues, and at the same time be ready to shake hands and work with the entities that are implementing the solutions to better understand not only implementation, but also how to improve the implementation such that when the partners and the project is done with and the funding runs out, there are sustainable systems that are put in place that would allow for those programs to continue running beyond the current funding or the funding that is available for the next 5 years.
That is a great answer. And Becky, I know in your role, sort of as the SVP of Innovation, you spend all day just talking to partners. So what would you add to what Gaurav said before we actually get about to move on to the tech partners? So this is great timing.
Yeah, I think it's really important. It might sound cliche, I guess, but again, be sure that you're partnering and falling in love with the problem first, and then determine like falling in love with the solution. So it's really understanding the problem and partnering that I think really will result in different results and being able to test new things that are sustainable. The other thing I would add is it's really important. We all know from an interoperability standpoint, and when we say that word, I think oftentimes we immediately go to workflow, and certainly that's extremely important. If it's not, implemented, ingrained within someone's workflow, they're not going to use it. But I also think it's really important from an interoperability to be thinking about the data. How is the data being shared? Because that's how we build knowledge, right? To be able to test some of these new solutions, new ideas, new platforms. And it's really important, again, to your point, as we're thinking about the partners coming in, how is that data being shared? What does that look like to really be able to get us to a transformed model that is sustainable?
So you've both made it very clear that in order to get to sustainability after this 5 years, you better have looked at the contextual issues, you better have talked to the people on the ground, and you better have managed your data very, very well. Okay, thank you again so much for your time. We're actually now going to be moving on to Dr. Tatiana Harilak, who is the CEO of Hello Sono, and Scott Stoddard, who is the Market VP for GE Healthcare. And we're going to be wrapping up today having the all important conversation that we've been setting ourselves up for. Like, what does make a good partner, and what does it mean when you've gone all the way from the discussion about how did the money come from the feds to the states, to big tech platforms and to the health systems, but now you're on the very, very front lines. Hey, Scott, there you are. Great. So if I could just ask Scott, if you could quickly describe your role, and then Tatiana, if you could actually describe HelloSono, and then I'm going to come back with some questions about how you guys perceive being a good partner in rural environments.
Sure. Thank you, Kate. And thanks for the opportunity to be here and for including GE Healthcare in such an important initiative, important topic today for the webinar, and such great conversation so far. My name is Scott Stoddard. I'm a market vice president with GE Healthcare, serving a tri-state area that covers the eastern half of Pennsylvania, southern half of New Jersey, and the northern half of Delaware.
Tatiana, where are you based today? And if you'd like to describe HelloSono.
I am joining you from New York City, and I am an emergency physician who's been using POCUS clinically for over 15 years. That includes urban emergency departments and also in rural areas and under-resourced areas like Everest Base Camp. And the reason why I started HelloSono is really with a mission of empowering clinicians to use this tool clinically to deliver better patient care. So with HelloSono, we are really focusing on addressing a barrier around clinical competency with using POCUS, and also the lack of operational readiness within the healthcare systems and organizations.
Thank you for describing that. And for those who are unfamiliar, we're talking about POCUS' point of care ultrasound. And it is, I think, the use of new technology is a great way to sort of enforce that workforce pillar, which is so key of our HTP. So, Scott, if we could just pop back to you. Obviously, GE Healthcare is one of the largest medtech companies in the US. But what you have heard from all of the speakers before you is that doing the same old is not going to cut it. You are going to have to be partnering with people in rural environments differently and truly listening. So from your personal perspective, how do you think the large medtech companies should be looking to partner with people in rural environments differently than maybe you've done before?
Sure. Well, it was great to hear all the commentary, and especially just now from Becky and G talking about listening to learn, not necessarily listening just to respond, but listening to learn, listening to understand. And we need to take that information, and with the Rural Health Transformation Program, we need to find ways to bring healthcare really closer to home, closer to the patient. As the other Dave was talking about earlier, we need to be able to provide that better access. And in doing so, we need to reduce the burden for rural providers, not add to it. And with all the challenges they're facing that have been discussed around staffing shortages, the looming financial pressures, especially with the Medicaid cuts coming in January, rural communities, as we see it at GE, aren't as much underserved as they are under-resourced. So they've got great people working every day, some of the best in healthcare, but they just don't have enough. So we need to help more with the resources, both from a workforce standpoint as well as from a technology standpoint. But the answer isn't just bringing in more technology. I think no rural hospital today is saying, I need another workstation or I need another piece of heavy iron necessarily. What they're saying is, help me give my patients greater and easier access to care. So when we think about being a great partner, it really starts with our mission, and you can see it over my shoulder. It's our purpose to create a world where healthcare has no limits. And if you think about it, to me, no limits starts with access. It starts with no patient having to drive an hour or more to seek that care. It's bringing digital solutions. It's bringing remote. It's optimizing the cloud. It's AI, but it's responsible AI. We need to be really sure that we're providing the right AI solutions and not just any AI. But around access, it means better access through the technology, any technology that can bring care closer to home, cloud-based digital solutions, packaging the right aspects of our portfolio, whether it's bridging together ultrasound, which is quickly becoming the gateway to the health system, especially with handheld and portable ultrasound, CT systems, C-arms for surgery, patient monitoring, and service, the reliability, especially in our rural communities. We need to make sure we're reliably keeping our equipment and technology up and running almost constantly. all of this under one umbrella. So partnership means accountability for outcomes, not just delivering the equipment. It's how do we deliver better care today while building capabilities and capacity for the future. And finally, I think good partnership means partnering with the right third parties as well, where we don't have expertise. Groups like Remote Rad Tech for remote access, and Hello Sono as another example with Tatiana as a great partner where it's not necessarily our expertise. So where can we find help and fill those gaps?
You made a comment during that about there being no limits, like when you're thinking about access to care. And I know, Tatiana, when we had a chance to chat before about like the very wide array of places that you have used POCUS to actually get there on the ground and do earlier diagnosis. I know you gave me some examples from rural Texas. I'd love to hear your perspective on how you are leveraging POCUS within a no limits environment, and then also get your insights on what else has to be true about that environment. What has to be true about the rural health providers, and what do they need, as you are one of them?
Focus is simply an amazing tool and someone who knows to apply it, right? So it can help us diagnose pneumonia at the bedside. It can help you look for a blood clot and decide whether the patient needs anticoagulation, which is a blood thinner, or they need to go to an emergency room. So you really can make decisions with this tool at the point of care. And I think what we are finding is that clinicians are excited to learn it. They do see the utility of it, but there is definite lack of continued support around getting them trained. So what we are finding is, especially in the rural settings, they do need more longitudinal training, not one-time workshop and they are done. There needs to be some type of supervision and feedback on their scans, so they are at the point where they are confident in their skill and they grab POCUS because they know what they are doing with it and they know they can make a clinical decision. So that's one big piece. Piece is that longitudinal training and support. And another piece is really the infrastructure. There needs to be an infrastructure in place around point of care ultrasound that includes, do you have credentialing protocols? What happens when you have a new staff member that comes in? Can they just start using the equipment on the patients? Do you have an archiving solution that fits well with the clinical workflow of the provider? Is it easy for them to save images and then document them in the chart? So that's one of the things we work with organizations to figure out, and also that billing component. So if you are an organization that's introducing POCUS, it does come with CPT codes and you're able to bill for it. So how do you leverage that so you can offset some of your investment and the costs associated with this? So those are just some of the pieces, and the big one is really quality assurance, ongoing quality assurance, building that either internally or externally, but you need to maintain that quality throughout.
So you mentioned something that's I know is top of mind for everyone, but not necessarily been mentioned somewhere, and that is the credentialing and education. And within our HTP, every single state, I think, within their narrative is talking about how do you not just bring in the new technology, but actually make sure that people are able to leverage it. It's great putting the tech in their hands, but they've got to be supported in the long term. Do you have any examples that you'd like to share with us of where you've actually seen its made sort of transformation? I know you've been up to Alaska. I know you've been in rural Texas. Is there any particular example you wanted to share?
Yeah. We are currently working with a critical access hospital in Northern California, where the emergency department is actually staffed by non-emergency physicians. They don't have the emergency medicine residency training. So they are either internal medicine or family physicians, and they happen to have an ultrasound device there, except that the training does not meet the standards that are put out by American College of Emergency Physicians. So we've been working with them to elevate everyone's training and confidence so they can meet the standards that currently exist, right? Whether it's you are managing a patient with congestive heart failure and you're looking for fluid overload, that's expected of an ER physician to be able to do so with POCUS. Or it's a trauma patient and you're looking for internal bleeding. Similarly, that's kind of the standards we are helping them meet with the training and the ongoing support and the reviews that we do for them remotely to support this initiative and really ensure that the rural patients in their communities are getting the standard that is expected in the emergency department in the United States.
So really helping support them on the ground once maybe the money has flowed all the way through down to the front line. And sort of, Scott, just to sort of finish up with you before we wrap up, from your perspective, I know you made a big point about saying, you want to be a partner, you want to be there right at the beginning and helping them think. Are there any other resources that you want people to sort of understand that GE is there to have the thought conversation?
Sure. Kate, I think, and as Tatiana was talking, technology really becomes an event, the adoption of technology, but capabilities across the continuum are more of a journey. And we think of it as an ecosystem. So when you think about equipment, connecting clinical expertise, the education piece that Tatiana brings out, digital tools, quality infrastructure, it really all has to come together as one. And that's how we're really viewing it. It's technology, it's workforce enablement, it's operational and quality support. I would point out one of our digital solutions is called Care Intellect for Operations, and it's a cloud-based digital intelligence platform. And what it does is it brings together real-time patient data with historical data that helps hospital leaders improve patient flow, capacity management, staffing, and overall operational performance. So it's solutions like this that are just bridging workflow and efficiency with the right clinical outcomes, operational, and ultimately the financial outcomes. It's taking down the cost of care. So I think the strongest partnerships are those that stay engaged long after implementation. I think, as G again pointed out, it's that optimization of support, it's quality improvement, it's the long-term success, that sustainability, which I think has been a key theme today. I would say also, maybe as a final thought, rural health transformation, the program itself, we at GE are spending just a disproportional amount of time around how do we measure baseline performance today in rural communities, and then how do we measure success in terms of access, efficiency, better clinical outcomes, and reducing the cost of care over the long term. That's the equation we're looking at now. So our ultimate goal is really to help rural providers become stronger and more self-sufficient over time.
Thank you so much for wrapping it up so nicely. I very much appreciate Tatiana and Scott joining the last part of our conversation around partners. Thank you so much. So I think that just leaves me to sort of wrap up the session. First of all, thank you so much to all of our speakers. We've really appreciated you taking the time to talk about the journey all the way from where did this come from the White House and the thinking there, how is it being disseminated through states into the health systems and then onto the front lines using technology. And I think what's clear out of this conversation today is that this isn't just about dissemination of funds and meeting deadlines and making sure you're talking to the right person. It's really about sustainably building capabilities and building the capabilities for the communities that you should have spoken to first before you think about implementing any new solutions. So not only thanks to all the speakers, but wanted to say thanks to everybody who dialed in today. We know that everyone that's dialed in is very busy. Thank you for your time on a holiday week, and we hope that you have enjoyed the session, and we hope to connect with you on future ones as well around rural healthcare.